Hi there. In today's episode of the Dr. Mollie James Show, I am just going to take you through a tour of how to break free from the healthcare system, why that is such an important thing for you to do to advocate for your own health. And I'm going to give you some real life examples and tips of what to do along the way to make it accessible for you. So here we go. We're going to get right into it. So, when we look at the modern healthcare system, unfortunately, what has happened is the product of the system has become the billable visit. So their product that they're selling you is just to get you through the door and engage with their practitioner and leave so they can bill your insurance for that. That is the product they're selling, and that is the metric that they're using for success. The more patients in, the more money generated. This is not an overly successful long-term plan. When you look at how we do it from an integrative perspective, our product, our end result that we are trying to measure and sell, if you will, but the product we are doing is outcome. The outcome for us is going to be resolution of your symptoms and improvement at the root cause, developing a lifelong relationship with our patients so you have a place that you can trust to get that advice that you need and get those reliable results. So this is a totally different paradigm. And when you understand it through that light, everything else makes sense. When you go into the system, you get a 7-minute visit because if you have a 15-minute visit, that's less widgets through the factory. During that 7-minute visit, the payer of that visit is not you, usually. It is your insurance. So guess who that doctor is serving during that visit? It looks like it's you. But it is actually your insurance because the only thing they need to know out of that visit, they do need to know what you said, but they really need to know what are the billable codes coming out of that, and did you hit the quality metrics necessary for the insurance purposes? Especially when you get to Medicare, did they get tested for hepatitis C? Are they updated on their flu vaccine? Have they had a colonoscopy? All of these endpoints feed the system. Again, in an integrative practice, any integrative practice, but I'll use mine as my most immediate example. If patients aren't getting results, they're not going to continue to see us. So we have to prioritize that as our end goal, is creating a wellness space, a healing space, and results-oriented care. So that is a huge shift in just what we're even offering at our core. The other thing, so again, on that paradigm, when you go into this 7-minute visit, they don't have time to address things as they should be addressed. So I was recently on the witness stand and I was asked a lot about the standard of care. And the attorney asked me, how does a medication become standard of care? And I said, it never does. And she didn't get the concept. I said, standard of care is not a treatment. It is how you approach a situation. So say somebody comes in and they've gained 20 pounds. Standard of care isn't to write a prescription for Ozempic. Standard of care is to address labs, address lifestyle, address diet, look at the thyroid. It's the approach you take is the standard of care. But you can't even begin to touch on that in a 7-minute visit in the system. This is why most doctors' advice when you go in is extremely abrupt. And it's things like eat less and exercise more. What if I'm doing that? What do I eat? You know, a lot of the doctors in the system, unless they have spent intentional time researching outside of the system, if they're following system advice, they're just going to tell you a low-fat diet. Studies have shown that that's not necessarily the case. So in an integrative model, we build in time because, again, we're results driven. So for us, it's not having the visit is our success point. Getting the patient to lose the 20 pounds or identifying how much weight they should lose is our end goal. And helping them reach that goal, that's our end point. That's our product. And we determine how many hours, how many visits does it take us to get to that end point. And this is, again, a shift in paradigm. We have patients call us sometimes that say, I just want one visit. Well, that in the old model may be the way it works. And there's thousands of doctors who will do just one visit if that's what you want. But we have determined to get through all of the information we need to get through to address the standard of care to the level we find satisfactory, we need 3 or 4 visits to get to know you and get to address and recommend some things and then have some feedback on that. So, this over medicalization in the system is actually causing problems. By the time somebody disengages from the system, now not only do we have the problem that started, we have the underlying effects from the medication potentially. So, just food for thought. Why do doctors in the system burn out so much? When you are given responsibility without authority equals anxiety. And I recognize this as a surgeon. I took on the responsibility of operating on a patient, potential, and doing all of the post-op care with the outcome that they would do well. I didn't have the authority to make sure things went right in the hospital. And when I did call it out, it didn't follow correctly. The hospital came down on me for calling it out instead of the person I was calling out for not managing the patient the way I saw fit. So that's a problem too. That creates burnout in physicians. Also, most people go into medicine with the intention of helping people. That is the goal, at least when you start. I've interviewed enough medical student applicants. Everybody says, I just want to help people. So that's where they start. But how much do you think you're helping people if you're chipping away at 10 patients an hour and just writing scripts all day? This is why people are burned out. They know there's a better way, but most of them feel trapped in the system because they have student loan debt and they're getting a regular paycheck. And to disrupt that delicate financial balance as a physician in the system is incredibly difficult. And unless you're ejected out of the system or you really plan for it, it can be a difficult thing to do. I had a little bit of both. I had planned because I had worked a lot during COVID. So I was financially able to do that, but I was also ejected from the system because I didn't do it on my own the first 2 or 3 times. So this is why doctors are so burned out in the system. They want to do a good job. They want to have that extra information. A lot of them feel powerless because of the way they've been siloed into a tiny thing. And then they have used car salesmen as hospital administrators telling them what to do and how to practice. I remember a friend that was and a colleague that was an orthopedic surgeon and had a meeting with administration, and administration told them, you are not operating on a high enough percentage of patients you're seeing in the clinic. Can you imagine the gall of somebody telling a surgeon you're not operating on enough people? That's asinine. And the surgeon said, yes, because we're experienced and we're not going to take people to the OR unless we know we can help them. That was the response. They were well-seasoned, highly ethical orthopedic surgeons that needed patients to lose weight and reach the other parameters, and they weren't wasting operations they knew wouldn't improve the patient. They were ethical. And what did administration do? Came down on them hard for that. So again, system burnout. These doctors in the system, unless they have found a way to fill up their bucket and, maintain a sense of purpose throughout this, can tend to be burned out. And there are some good doctors in the system, don't get me wrong. I know a lot of them that's just where they tend to practice. How accurate do you think a diagnosis can be in a 7-minute visit? Misdiagnosis is actually one of the things that we see most often. And just because everyone's doing it that way doesn't make it the right way. So again, when you go to your doctor in the system and say, hey, I need to lose 50 pounds, that doctor is probably going to say something like, well, here's a weight loss pill and eat less fat and exercise more, period. So when we look at that, what we have found is there are a lot of patients who are actually hypothyroid. They're high insulin. And so we have to address these underlying causes that aren't even looked at, let alone diagnosed. So there's a misdiagnosis of the underlying cause, which is why these solutions in the 7-minute visit never get to address it. And making this even worse is not only now do you not get a 7-minute visit, there are companies out there such as Amazon and Hims and Hers. You've probably seen the advertisements where you can pick up your phone and you can text somebody your symptoms. And a doctor will review that and they'll text you, and the magic shipment of your happy pills will show up in the mail. One of those advertisements is specifically for antidepressants and targeting young women. It doesn't talk at all about the side effects of SSRIs. It doesn't talk about the long term consequences of that. It doesn't talk about the true purpose and the safety studies of those, which have no long term safety studies. So we're getting even worse care. Even it's becoming a prescription vending machine. And what's going to happen is on the back end of this, because we're not addressing things at the root cause, just like we're seeing now. Now we have to back up and address it at the root cause. It's so much more expensive because the damage is so much deeper by being in the system model for that long. We do have patients, though, that take that step. They say, hey, I've spent a lot of money on this. I've gone to a lot of doctors, but I think you can help me. And they give us one more chance. And I tell them, I need a leap of faith for about the first 2 to 4 weeks. And after that, if you're not seeing it, we'll do something different. And they come to us and they start to see results. They start to see we're going to look at this a different way. Because if the mind is trapped and nothing is going to work for me, nothing's going to work. Nothing has worked. Nothing anyone's tried. No one can figure this out. If a patient gets in that mindset, that mental mindset so long, it's extremely hard to get that flip to, oh, it's starting to work. And we need that mindset on the path of success. So when somebody comes to our clinic, my number one goal is to get relief of symptoms of some kind within 2 weeks. We've got 2 weeks to get a result. Especially in the weight loss realm, that can be a little tricky because if someone has an insulin level of 35 or 50 when it should be 5 or 10, that I call it invisible weight loss. We have to drop that insulin down first before we're going to see the weight loss. So that first 2 to 3 months, 4 months can be in that realm. So what is the current system? The current system, unfortunately, has been taken over. Insurance happened in about the 1970s, 1980s, I believe, is when it became more standard. And what the thought was is most of the population is healthy, but you're going to have a tiny percentage of people with things like type 1 diabetes. You're going to have these very rare cancers. So we can all pool our funds so that when we need something, there are funds to pay for it. We have a safety net of security. And we can help offset the cost of those who are unfortunate with a specific diagnosis. But what has happened is everybody's sick. Insurance was never designed. Think of auto insurance. With auto insurance, you don't use that to pay for your oil change. You use that to pay if you get in a really bad accident. Even if you get in a minor accident, sometimes you're going to just pay for it out of pocket to avoid deductibles and things like that. Now, take that and apply it to healthcare. These preventive health, these wellness visits, these should be out of pocket investments that each person is willing to make into themselves. And on our last episode, Carrie Meyer said it beautifully. You are the biggest asset to the people in your world. Investing in yourself is the most important thing. So it is worth it to do that. The lack of personalized care. When's the last time you called a medical office and you knew the doctor you were going to see? There's a number of things that have shifted now that it used to be you would go to your doctor, you would have a primary physician, they know your name, you know their name, you're going to walk in, you know what's going to happen during that visit. And it's a trusted source of information. But due to practices being corporatized, these individual practices are bought up by corporations and now shift work. So people want a nice lifestyle when they're a physician. I don't blame them. They want days off. So you never know when you're going to be able to get into a doctor or who you're going to see. And they're not going to know you. I can tell you when I know a patient and they call in for something, I know how reliable they are. I know how effectively they're going to follow up with me. And I can gauge that risk as far as can I just send in a prescription for them and I know they'll follow up with me if they don't get better. It reduces the cost of healthcare when you have that very personal relationship with your medical team. That is extremely critical to the bottom line as far as reducing waste. It does you no good to go into an urgent care because you have a urinary tract infection and end up with a CAT scan, a urine culture, and all of that on first round. That's very expensive care for something that could have been a $5 antibiotic prescription from somebody that you know and trust. not to mention the downstream third and fourth order effects of having too many CAT scans and things like that. So, this defensive medicine that doctors feel like they have to practice because of the way the system is designed minimizes substantially when you actually know and have a long term relationship with your medical team. Very important. Patients get lost in the system all the time. Since 2020, and I don't know what happened in 2020 that could have changed this, the system has been absolutely overwhelmed. We have patients that call for specific consultations and they get told a neurologist is a year out. To get into a cardiologist is 3 to 4 months, 6 months for an established patient in different practices. So patients are truly getting lost in the system. It's not uncommon. We have patients call our office very upset because they say, "You didn't send in my consult," or "You didn't send in my this or that." We have documented where we've sent it in multiple times and our orders and our referrals get lost in the system. This is why the concierge model is so beautiful as well. How many times has a doctor recommended you get labs? And you went in for that one-time appointment and left. Did you get your labs? But if you're in a concierge model where you have that monthly financial commitment and you know every month somebody's going to be calling you and checking in with you, you're more likely to get those follow-up labs, more likely to make on the fly decisions. So instead of this was a great analogy someone shared with me. So on a flight from Chicago to Paris, the pilot doesn't check in 5 minutes before landing in Paris. They're checking in the whole way on the flight to make sure to reroute the flight if they start to go off course. The same thing with your healthcare. If you only check in once a year, you could go very far off course before you get back into it. That monthly accountability, this is why we've gone to a concierge model in our own practice, because we've found that it enhances those outcomes for our patients so much just to have the subliminal knowledge that someone's going to call you and check in with you. You're going to stand on a scale, not punitively, but so that we can assess and keep track of your progress. And if it's a little bit off kilter, we can encourage and motivate you to get started again. Yesterday, I had a patient, and she hasn't seen me in over 6 months because after she got her last set of labs, she said, I got really discouraged and I just went off the handle and I ate whatever I wanted to because they weren't good enough. And so I pulled up her labs that I didn't have a chance to go over with her. And I said, these are actually pretty good. You actually did pretty good from the time before to that time. And you getting discouraged because you didn't check in with me and I explained it to you. So I said, that's okay. We're going to reboot now and we're going to get going now and we're going to reset now because you can make these changes and you are going to see results. So, we, even within our concierge system, sometimes we have patients who get discouraged. But imagine having an entire team of people who have your back and encourage and motivate you and answer your questions all the time. It's so much better. One of the things people get concerned about is if and when I exit the system, how do I do that financially? And we've given specific open forums on this and how to do this. There are a number of ways. One is that most patients have gone to a more high deductible plan. So if they end up in the hospital or in the emergency room, they have that safety net coverage, but they know that they're going to have an out-of-pocket cost. And then we operate under the plan to avoid hospitalization if at all possible. Now, we have patients we've sent to the ER from our hospital or from our clinic because they were having active chest pain and a non-STEMI. They were having, a couple of times they were having symptoms. So there are times when we want that ability to go to the system if and when necessary. But going to a high deductible plan, building an HSA, a health savings account that is pre-tax dollars that can be pulled out into a medical account and spent however you want it to be. It can be glasses, braces, infrared sauna. It can be red light therapy. It can be Botox injections. It can be IV vitamin infusions. It can be concierge. Wherever you want to spend that money, you can do that through an HSA, health savings account. There's a flexible spending account. Some employers have plans that offer this. It's a little bit different. It's a little bit more specific in the coverage. So they do ask for details of how you're spending that money. That's another way that you can access things that are a little bit outside the system with your own money. Some people are doing health sharing accounts. So, a little bit like the insurance model where they can get reimbursed for the care that they want to have. And then there's people that just straight self insure and they pay cash for things. So, we had a young lady who took a tumble and she fell and ended up in the ER needing a CAT scan of her head, which was totally appropriate after that severe fall, and needed staples in the back of her head. That hospital stay would have been $10,000 or $12,000, my guess, if she would have gone through an insurance-based model. She said, "I pay cash, so what do I owe you today?" Do you have any guess on a $10,000 to $12,000 supposed hospital stay through insurance, what that cost her cash? I believe it was around $850. So the cost of healthcare becomes so much less intimidating when you take out all of the layers that you need for the insurance reimbursement. In my own practice, I took insurance at one time. And you cannot operate a successful business on that because you basically say you charge $100 for a patient visit. You submit that $100, you may get 45 to $50 nine 90 days from now, 120 days from now. It doesn't create a cash flow situation. If you're a business owner, it doesn't create a cash flow situation that's sustainable because my employees don't want paid 90 days from now. They want paid now. So it is not a sustainable business model from a physician's side of it. But think of all those layers of administrative support that that insurance billing is going to when it is collected in the system. So, what does self advocacy look like? So, how do you begin this process? And a lot of what we do, especially in our cancer patients, is we help them advocate for themselves. Number one, ask questions. We help our patients formulate a list of questions to ask. So many people get nervous when they go to the doctor. They get nervous. So asking questions, having a notebook that's just for your health information. That way, have a page for each doctor and just write those questions as you think of them and bring them into the office so you get all of your issues addressed per appointment is a really good way to do that. Seeking second opinions. Have you ever asked a doctor for a second opinion? If they don't tell you emphatically, yes, I want you to go get it, you don't maybe want them to be your doctor. If a patient asks me for a second opinion, I always enthusiastically say, go, please do. I will give you some names of people because you're either going to find out I knew what I'm talking about, you're going to come back and we're going to have a great working relationship. You're going to find I knew what I was talking about, but you like the other doctor better, which is better for your care. Or you're going to find new alternatives that you may want to consider, but you'll have more informed consent if you do get that second opinion. There is a law of diminishing returns to this. I have people who go to many places to get second, third, fourth, and 10th opinions. And it gets to be a little bit confusing if you get too many opinions. I was once told put 20 doctors in a room and ask their opinion and you'll get 40 of them. So a second opinion from a trusted source would be highly recommended, but don't carry that too far also. You have the right to refuse any testing or any medication that you want to, any procedure that you want to, with very few exceptions. There are a few exceptions in the mental illness realm of things and very specific scenarios, but for the most part, you have the right to refuse any testing or any medication. This was grossly violated during COVID when we had patients with life-threatening conditions that were refused care unless they would get a COVID test. In my opinion, anybody who engaged in that behavior should lose their license immediately. And most of the situations, a COVID test wasn't even indicated. For example, somebody was in a car accident and bleeding out, and they wouldn't take him to the OR until they had a COVID test. That's ridiculous. You have the right to refuse any drug you want to. As early as last week, I had a patient who felt a little dizzy episode. And one thing escalated to another, escalated to another. He ended up in the ICU having been given TPA or a clot-busting drug for a stroke. He told the people in the ER, I'm fine. I don't need this. So, what was probably a 6 to 8 hour dizzy spell, which he had never had before and has never had again, became probably $100,000 hospital stay because they were trying to CYA, cover their ass. You, as the patient, have to be empowered to say, stop, I'm not going to do this. Along with that, you assume the liability for what would happen next. So if the patient refused the TPA and went home and had progression of a stroke, they assume that liability. But we get to make those choices. The same thing patients ask me with mammograms. I get asked this question all the time. What do you recommend on mammograms? I say, what's your risk tolerance? The whole point of a mammogram is to detect breast cancers earlier so they're more treatable. What I'm finding now is that on those early stage breast cancers, they're hitting people with chemotherapy and radiation really hard up front. So, what could have been a surgically curable treatment now gets them into recurrent cancer because we've overtreated and knocked out their immune system. But whatever your risk tolerance is, your screening has to fit into that, and you have to assume the liability. I don't want patients out suing doctors because they didn't want to get a colonoscopy when they turned 50. That's your choice, not the system's responsibility. Along with that, becoming your own advocate, one of the things I highly recommend is for you to get copies of your own records. Every time a patient comes into our office, we give them a copy of absolutely everything. And you need to keep that in a binder and you need to keep that dating back. One of the most memorable cases from when I was a surgeon, I had a young lady come in with right upper quadrant pain. And she had pain after she ate. She had bloating. She had an ultrasound that showed her gallbladder was distended with stones in it. And I looked at her abdomen and she had three little incisions. And I said, what surgery did you have? She said, well, they used a laser and they took the stones out of my gallbladder, but they didn't take out my gallbladder. I said, we don't do that surgery. You probably had your gallbladder removed. No, I absolutely didn't have my gallbladder removed. They just took out the stones. Now, I'm a board certified surgeon. I know that procedure doesn't exist. However, I'm stuck. I've got a patient with biliary colic. I've got an ultrasound showing a gallbladder in the gallbladder fossa. So I tried to obtain the operative report to get me out of this operation and clarify what procedure she'd had, because sometimes patients get confused and sometimes crazy things happen. We tracked it back to her hospital, and the hospital had been bought out by another hospital. Nobody had the operative report. So I take her to the operating room. I access the abdomen, I blow it up, I lift up the liver, and guess what? There's no gallbladder there. So it is really critical that you hang on to admission documents, discharge documents, procedure documents, any kind of operative reports, and especially the pathology. So people forget you have your gallbladder taken out, but I need to know what the path showed because that's where we're going to make decisions. That's where we know, was it cancer or not cancer, what was going on. So those are the critical things that you need to hang on to. Now, with the conversion to electronic medical records, what they have done is taken a document that would have been 2 or 3 pages back in 1990, and now it's 500 pages. So now when I get these charts, I get giant stacks of documents that are absolutely worthless medical information. Maybe there's 2 or 3 half pages in there that are relevant to what we're talking about. So they bury us in paperwork. But still keep those critical documents for yourself so that you can bring them. And I tell patients, get copies on a CD of all of your imaging and bring it to your different doctors so you know they have it and you know they can look at it. Do not trust a third party to send it to a third party because none of those people have any investment in that, making sure that gets there for your appointment time. If you bring everything, there's no questions. Some other things that I recommend, keep a health journal. So I have patients who don't want to take blood pressure medications. They're maybe high in the office. They say, every time I check at home, I'm totally fine. Well, keep a log of that, and I'll put that in my medical chart because we still are upheld to medical standard of care. So if your blood pressure is high, and I don't treat it, and I don't document that it's not high at times, I have some medical liability. Unfortunately, that's the world we live in. So there has to be a little component of that, even when you're outside of the system, to operate differently. So keep that health journal, keep track of things, keep calendars, and score your symptoms so we have something to go on. Not all practices do what we do, but not only do we help you, but we demonstrate and show you objectively how we help you over time. So we use things like medical symptom questionnaires. I remember I had a patient who came in and said, I've been doing this for 6 or 9 months and I'm no better. And I said, oh, okay, let's go back. So we looked at the medical symptom questionnaire, and the initial scores were in the 80s and 90s, and the 6 month scores were in the 30s. So when we pointed that out and we talked about it, they said, oh, yeah, this symptom's better. And, this is better. My energy's better. So not only do we have to help people, we have to demonstrate to them how we've helped them as they start to feel better. Knowing your rights as a patient is really important as well. Knowing what your rights are. And again, this is so askew right now because during COVID, the rights of patients were so heavily violated that creates an era of some confusion. But you have the right to be seen in an emergency department. You have a right to leave the hospital anytime you want to. And anyone who tells you you can't come back to the ER if you leave against medical advice is lying. Anyone who says, this was a common one, if you leave against medical advice and need to be readmitted, your insurance doesn't cover it. That's not true either. Insurance payment for services and your rights as a patient are two separate entities. They're two separate issues. So you have the right, you are an autonomous being, and that's one of the bioethical rights. You have the right to make your own healthcare choices. So how do you start to exit the system when you're deep into it? You have multiple specialists, very complex care. Does that require an army of specialists? And the answer, sometimes it does. But what I have found is the sicker the patient is when they present to my clinic, the more simple our solution starts to be. For example, what are you eating? How much water are you drinking? Let's start with the very basics and let's start to build on some successful patterns. Every single patient that I see, I want them pooping, drinking water, eating properly, and sleeping on schedule, and maybe some activity or movement throughout their day. We've got to get those 5 covered. Everything, if you see everything as a pyramid, we've got to get some of those lifestyle things on the foundation addressed before we can move to other things. So when shouldn't you exit the system? When do you have to have resources? So acute hospital care is very good at certain things. I used to be a trauma surgeon. The systems are very good for trauma surgery. They're very good if you have an acute accident, an acute injury, and taking care of you. That's what it is designed for. If you're having a heart attack, a STEMI, ST elevation MI, the system is designed to expedite your care. If you're legitimately having a stroke, not an episode of dizziness, the system is designed to get clot-busting drugs into you in a timely manner and get you evaluated. The problem is that people doing the evaluations these days just don't seem to be as invested or as competent as they used to be. So, so we do need to cooperate and interplay with the system. And this is one of the things during COVID that really broke my heart is a number of patients came to us who were terrified of going to the hospital. And we developed a great working paradigm, but we had several bullet points of indications that the patient had to go to the hospital because we couldn't safely manage them at home and in a virtual environment. Things like confusion. If their mental status changed, they had to go to the hospital. If they weren't able to get out of bed, if they had that weakness, we needed labs and we needed to manage that. So I didn't want them afraid of the hospital. And I do believe the majority of people who are there, again, they're committed to helping you. They're just in a system where they're burned out. So to wrap this up, leaving the system is going to be worth it, at least for your day-to-day, your chronic care, your proactive wellness. People wait to find a doctor until they're sick and they're at rock bottom and they can't tolerate it one more day. So we're used to that. We're used to taking people from 10 feet in the ground in a hole, trying to get them to some level earth. But what we really enjoy after we do that is, from this average or operating position, let's get you to the summit. Let's get you to ultimate performance. Let's get you to a situation where your greatest gifts shine the brightest and you can make the impact that you were made to deliver here on earth. So that is really a source of enjoyment. And it's a lot of the same strategies. It's just, where are you on the spectrum? Are you deep in the hole and need to get out? Or are you on par and just want to be that high performing athlete, that professional athlete, that special forces person, that military operator, bodybuilder, competitive athlete? Where do you want to be on the spectrum? And we can help you get there. So I hope that's been helpful. Drop your questions down below and we will try to answer all of those for you. Make sure you're at least following along James Clinic, because we do offer a lot of advice to people for free. And we look forward to seeing you on another episode of the Dr. Mollie James Show real soon. Take care.